Good morning, afternoon, or evening, depending on where you're joining us from, and welcome to today's first session, A Treatment Pathway for Classical TN, featuring Dr. Raymond Sekula and Dr. Joanna Zakshevska. I'm Brandy Underwood, the Manager of Development, Research, and Advocacy for the Facial Pain Association. Before we begin, I want to go over a few housekeeping items. On your screen, you should see an option for both Q&A and chat. We encourage you to connect with other attendees using the chat feature. Please reserve the Q&A for your questions, and we'll get to as many as we can following the presentation. I plan to monitor both, but using the designated option will hopefully allow us to get to more of your questions. Although presenters today may be doctors, they are not serving as your doctor during the Q&A and are unable to answer specific questions about your health situation. We request that you keep your questions general in nature, and we will do our best to select questions that will benefit most people living with facial pain. Now, it is my pleasure to introduce our speakers. Dr. Raymond Sekula is a professor of neurological surgery at Columbia University and chair of the FPA's Medical Advisory Board. Dr. Joanna Zakshevska is a facial pain consultant at the Royal National ENT and Eastman Dental Hospitals and Pain Management Center at the National Hospital for Neurology and Neurosurgery. After obtaining her dental and medical degrees and specialist training in oral medicine, Professor Zakrzewska went on to specialize in orofacial pain. Her MD on trigeminal neuralgia led to further clinical research in this field. She spent 10 years as an academic at Queen Mary's School of Medicine and Dentistry, where she was awarded a personal chair in facial pain. In April 2007, Dr. Zak moved to an NIH post at Eastman Dental Hospital, University College London Hospitals, in order to set up a National Center of Excellence in Facial Pain. She has written 4 books on orofacial pain, contributed to over 10 chapters, and written over 80 peer-reviewed papers on the topic of orofacial pain. She lectures extensively, both nationally and internationally. Dr. Zak, Dr. Sekula, it is an honor to have you with us today. Please take it away.
Thank you.
Thank you. So, good afternoon, and thank you very much for giving me an opportunity to talk to you. It's a great pleasure to see so many of you joining this, and I'm going to particularly concentrate on a care pathway that we have developed at UCLH, my London trust that I work for. So, although this seems a very busy slide, I'm going to take you through this very slowly. But the important factor is that, firstly, patients are managed in the primary care sector, which, as you've probably heard, is quite difficult sometimes. Patients, when they come to our facial pain unit, get carefully, as we call it, phenotyped. That is, their history is taken very carefully. We give them questionnaires to do, which give us an idea of the impact that this pain has, and I'll show you some of that. And then we do MRIs. Based on that, we can then differentiate between patients who have got symptomatic trigeminal neuralgia. Those with tumors and vascular problems need to go to the neurosurgeons. The MS patients, multiple sclerosis patients, can come back into our service. We begin drug therapy, and we have a range of people to help with this. But very early on, we do a joint clinic with the neurosurgeons, with myself present or another physician and a neurosurgeon present. And here we discuss what potential surgical options are open, and patients at this point can make a diagnosis of whether they want to have one of these procedures or whether they want to be managed medically. We also offer a pain management program for patients, which involves our psychologists and our physiotherapists. And I'll take you through some of these stages. So firstly is these key features, and I would hope that those of you who've got classic TN would relate to this description by one of my patients. So the key features are that it has to be in the distribution of the trigeminal nerve, as shown here. It needs to be described, as you know only too well, as a sharp, shooting, electrical type of pain. The attacks are single, rapid, and come down rapidly, but you can get series of attacks of pain, particularly when it becomes more severe. And the severity is very high, 10 out of 10. And there are periods of remission when it suddenly seems to disappear completely. The pain classically is provoked by light touch activities, particularly around the mouth, talking, eating, drinking, but also washing your face. In the dental field, we can often see that one side of the mouth isn't cleaned as well because it's too painful to do this. Sometimes there might be some sensory changes, and either the clinicians or your significant others may well see you having an attack of pain. So again, you'll have had a lot of talk about this, looking at neurovascular compression. And in the classical cases, what we mean is that we can see this vessel pressing on this nerve. And this is an example. And this is the nerve here coming down and then going out there. Now, the impact is huge. And this is some work we've been doing for a long time, filling out the brief pain inventory. And the green bars show you the significant impact. So when you are in a severe flare-up, when the pain is very severe, you can't do these various activities. And the other important fact is the isolation. And this is one of my patients who paints herself being on this island with her electrical chair, isolated from the rest of the world because it's rare. Nobody understands it. You look normal. And the other factor is the fear factor. You are fearful of when the next attack is going to come because it's totally unpredictable, and fear drives even more pain. And our work also shows, and this has been replicated in big data in Taiwan, that patients become very anxious, depressed, and have significant concerns about their pain, and sleep habits are disturbed. So it is well recognized that this disease has huge impact on quality of life. We have a variety of guidelines. We first did guidelines internationally with America and Europe in 2008. Subsequently, the European ones have been updated in 2019. We have done some in the UK, and we're hoping to update the American ones as well. And Dr. Sakula is very keen that we should update the American ones as well. What my PhD student has shown, that what matters to you, this is work we did with patients in focus groups, it's not just pain relief and decreased pain intensity, but as you see, it's health-related quality of life, being able to participate in social activities, being satisfied with the treatment, and not getting too many side effects. So we should be monitoring all these outcomes, not just about pain relief. It's not the only factor that's important to you. So what are the medical therapies? Well, we know that the first-line drugs for classical trigeminal neuralgia are the anticonvulsant drugs. They are effective, but tolerability is poor, and they need long-term monitoring. Neurosurgery, when life is dreadful, when you have poor quality of life, major surgery is the best option if you have a neurovascular compression. And I'll go into a little bit more of this later. Or if you're not medically fit or too fearful of having a major procedure, minor surgery can also give you good results. So according to the guidelines that are published internationally, first-line drugs, carbamazepine and oxcarbazepine, those are the official pharmacological names for them. These two drugs are certainly first-line drugs. And then we have less evidence for a range of other drugs, which can be used in the secondary care sector. And you can mix the drugs, as we call polytherapy. So you can have a mixture of one from the first line mixing with another from the adjuvant therapies. It's also important to know how to cope with acute treatments when you have a very severe flare-up, which takes you to the OR room. So lidocaine ointment, spray and injections are options. Sumatriptan has been proposed, which is used for migraines. Botox doesn't work fast enough, and many patients will end up needing an infusion of phenytoin and fosphenytoin. What is important for you to see is that none of the opioids, such as morphine and fentanyl, are options. These drugs do not work in this condition. So that's what's very important, that you don't get given these drugs. But the side effects are huge, and we've done a lot of work around this, and this is some that we've done. And the dark blue bars show you the major side effects: tiredness, memory problems. You talk about having brain fog, not being able to find the right words, sleep's disturbed, unsteady, you can't concentrate, weight gain, dizziness, shaky hands, double vision. These are all likely to occur, and that's why we need to keep the drug level at the lowest possible level to try and avoid these side effects. But they can have a huge impact on your quality of life. So important is to realize how the drugs work for you personally, and this is crucial. So I haven't put any figures on here because it is so individual. So what we're looking at between the two red bars, that's what we think is the therapeutic level. That is the level at which the drug is having an effect. And we want to try and keep it in this level. But if you take the drug, say, last thing at night, and then you don't take anything throughout the night, when you wake first thing in the morning, your drug level is very low. And yet at this point, you're trying to wash your face, have breakfast, do a lot of things that stimulate the pain. So what's a good idea is that you take the drug and wait, possibly half an hour, but I don't know. For every patient, it's individual. Wait till you're into this therapeutic level. And again, trying to get and prevent an overshoot, as we call it, because it's during this period that you're likely to get most of your side effects, because the side effects can vary. They can be worse at certain times and better at other times. So the aim is to try and be like this. And sometimes the slow release medication can enable you to ensure that you're in this pathway. But every patient is different, and you need to think about what is your own best timing of your drugs. And to help you with this, at the moment, we have pain diaries. We are developing, and for one of our drug trials, we've been using a electronic pain diary to record this. You can record it any way you wish, but it is important that, particularly when you're first starting with a new drug or changing something about it, that you get a feel for how much pain relief it's giving you, what activities it enables you to do, for instance, eating, washing your face, and the side effects, because it's the side effects that will also affect the dosage of the drug that you take. So some of you can tolerate very high doses, others less so. And we have shown that it's also gender related. Women are less tolerant of the particularly carbamazepine and oxcarbazepine. So monitoring, pain diaries are important, and blood tests from time to time. Again, depends how sensitive you are. Sodium levels can be very important, especially if you take oxcarbazepine. But again, it's an individual thing. So you need to learn and push your general practitioner to give you regular blood tests so you know at which point you're safe to take the drugs, doesn't have much side effects in terms of your blood, and is safe for you to take. And you need to be monitoring how much you take. And this is a difficult concept for some doctors to understand. I have a continual battle with my GPs who think, well, I just prescribe so much of the drug. And I say, well, no, sometimes the patient needs more, sometimes less. They need to monitor it. You become the expert patient. And it's crucial that you learn how to monitor the drug and how much you need, because if you're going through a remission period, you may want to stop taking of a drug for a while, or even take much reduced dosages. But your GP needs to know that at some stage you may need to increase it. I'm briefly going to cover the surgical ones, but there's many surgeons on board, and Ray Sakula is a major neurosurgeon, so I'm just going to quickly look at it from my point of view. Difficult is when and which surgeries should you consider, and hence the need, as I find it, that a physician and a surgeon are in the consulting room together. So patients, and we've shown this, our patients will ask first the neurosurgeon, then they'll ask me and say, what do you think, doctor? And then the patient plus their spouse, whoever else, we always encourage you to come with somebody else, because you only remember 50%. It's good if your other half can remember the other 50%. So the major surgery, as you know, is the microvascular decompression in classical. And then we have a range of ablative procedures that you need to be aware of, and I'm sure you've heard a lot about them. Just an example from one of my colleagues, Professor Kokum. This is 8 times magnified, and you'll have seen plenty of these slides, but here's a beautiful example of a huge vessel indenting the trigeminal nerve and then moved out of the way. And I won't talk about how you move it. I'm sure the neurosurgeons have covered this. And the ablative procedures, all overnight stays on the whole, but they are going to result in some loss of sensation because they are destroying nerve fibers, as opposed to a microvascular decompression, which is trying to preserve nerve function. Stereotactic radiosurgery, gamma knife, is the least invasive, but effects are delayed, and it can be up to 6 months before you get not only pain relief, but also side effects. So I've had patients who've said, oh, I'm pain free, it's fantastic. And then a month later, they say, oh, but I've lost some sensation on the side of my face. So overall, from the world literature, here we've got example of over 5,000 patients, 85% are pain-free at 2 years, 70% at 5 years. And these are the various side effects that can occur. Mortality is extremely low now in the hands of the right surgeon. So you need to be seeing a neurosurgeon who works in posterior fossa surgical procedures. But sensory loss is extremely rare because you're trying to preserve the nerve. But I think what this illustrates is that 30% fail, and that's because the cause of the pain is not just the vessel. And I think, again, that's been covered in other talks to explain why not everybody has 100%. Minor surgery, any of the ones I've mentioned, on average, 50% are pain-free, but up to 50% of you will get sensory change. And that can be very mild, just a sort of feel of pins and needles, but it can be quite deep and dense. So your whole side of your face feels numb, you dribble, you don't notice that your nose is running. Your partner has to tell you that something is wrong there. What I find is absolutely crucial is other support. So that's why we run a specific pain management program. We've published the data showing how important it is to meet fellow sufferers. And again, through the FPA, you can meet fellow buddies, which is extremely important. So it's wonderful that all of you belong to the association. We then teach you various methods of stress and relaxation, working through this fear, which is what I've mentioned, how debilitating the fear of pain return is. And the psychologists give you some help with doing this. And also what I find very important is developing a TN management plan. So I like my patients to know this is plan A. Plan B is this, plan C might be this. So plan A initially might be just drugs, but my plan B is possibly having surgery. So it's very important to know how to launch into the next one. And as you're very well aware, there are numerous pain groups around, and they have all been shown to be of great value, because even though I have seen hundreds of patients with TN, there's nothing like talking to a buddy, somebody who's been through it. And I think that's the wonderful thing about your association. And that's why decision making, and again, during our joint clinic, I ask all patients and give patients this form, so-called the Ottawa Personal Decision Guide, where you make the options of what you want. We mention in the clinic, this is option 1, option 2, option 3. You think through it, and this might change with time. You might change your decision based on the pain intensity, frequency, and response to medications. So as you see, I've shown you how we go through this pathway with getting you diagnosed correctly, getting you on the right drugs, looking at the response to the drugs through doing outcome measures and pain diaries, meeting with the neurosurgeons together, having some psychological physio support as well, so that hopefully we can get you in a better state of health and living well with the pain, even if we can't totally cure you. So some of you will be totally cured, but not everybody. And it's accepting that that isn't an option for everybody. And what we found from monitoring our joint clinic over 11 years, what it tells you here is 54% have opted to have surgery, of which 55% are pain-free. But we also have those who've decided to stay on medication. And even among that group, 16% are able to come off their drugs for a while. So it isn't all gloom and doom. I think the prognosis is better than we think. And not everybody has to undergo surgery. But I think the option needs to be there so that you can move and make your decisions about where you want to go to next. And if you want to read more, this is our latest book. There are chapters there written by patients from the support group. In fact, Claire Patterson, the founder of the American TNA, has written a chapter there. Patients have talked about their journeys through. There's a lay summary at the end of every single chapter so that everybody can understand it. So I hope this provides you with further information, evidence-based, because that's the problem. I say to my patients, don't go onto social media because nobody's there moderating it, nobody's checking it. So stay within your association, because that's where you're going to get high quality evidence and help. So thank you very much. And I'm open to questions, and Ray Sakula may jump in here and ask and modify some of the information that we've given. Thank you.
Well, thank you, Dr. Zakrashevska. For those of you who don't know her, she's just made tremendous contributions over the years and continues to make tremendous contributions. I strongly recommend, if you're looking for more information, to get a hold of this book, because anything that she edits is very, very high quality information. I'm going to show maybe just 10 slides quickly in less than 5 minutes, because I took a few notes during her presentations just to highlight a few items. She was very comprehensive. And then I think, Brandy, we can open this up to questions. So let me just grab the presentation. And Brandy, I apologize. I'm having a little trouble finding it. Maybe just you could pull it up for me.
Hi, Dr. Scholl. I'm happy to pull that up for you.
Thank you. So while Brandy's doing that, let me just say a few items. You know, this many individuals within the Facial Pain Association do not have classical trigeminal neuralgia. So you might think, well, this presentation doesn't apply to me, or not to be literal, but I'm not as good of a person because I don't have classical TN. Well, that's obviously not the case, and we, it is from a surgical standpoint easier for us to treat than some of the other types of TN, but there are many types of TN. So, Brandy, do you have that? Okay, so this is a list of just some of the types of TN. Okay, there are probably 15 others that I could talk to you about. And again, today we're talking about classical TN. Next slide, please. Now, as she mentioned, but this wasn't always the case. I mean, 10 years ago, and I must tell you, it didn't come from American neurologists. It really came from our colleagues in Europe, of which Dr. Zakraszewska and others were really very important in solidifying the concept that there are a subset of people with trigeminal neuralgia that have a blood vessel that's compressing their nerve, and that's the cause of their pain in most cases. Now, I should also suggest to you, though, that we also know that 3 out of 4 individuals walking around without facial pain also have blood vessels at least touching their nerve. So in and of itself, it means nothing. You can't look at an MRI, for example, in a vacuum. Next slide, please. Now, this is kind of how we started approaching imaging of the trigeminal nerve back in 2011. And at that time, this was not well accepted. But the yellow and the red are the trigeminal nerve, and the sort of orange cone shape is meant to imply the portion of the nerve that derives its insulation from the brainstem or the central nervous system. And we think, but we don't know, and there's a lot of that in trigeminal neuralgia, we think, but we don't know that that's really kind of the hot spot where blood vessels can cause pain in individuals with those so-called classical, or what used to be referred to as typical symptoms. So when we started to teach our radiologists how to read these, and in the US, I can tell you that still most radiologists, despite copious publications, don't know how to read these scans very well. And also most institutions don't know how to image patients with TN. So, what you really need in most cases, and I think I can speak for most or all of my colleagues who are neurosurgeons on the MAB, is that you want to image these patients in all 3 planes, meaning in this orientation, and this orientation. Next slide, please. Because we want to get at this so-called insulated or myelinated portion of the central nervous system, like this slide shows. And so that cone there that you see, that's entering into the brainstem, that's kind of the hot spot. Next slide. And so we apply that using these types of characteristics, and there are other recipes, but this is certainly a very good one. And what does this recipe mean? Well, this means unless you're trying to rule out a tumor or MS, and most of the time that's already, those kind of gadolinium enhanced scans have already occurred before a patient comes to us. This is an excellent way to visualize the nerve in all 3 planes using what are referred to as heavily T2 weighted imaging. And there are acronyms for different companies. So like Fiesta is a GE's proprietary software, and KISS, CISS, is Siemens, and Toshiba has them. And so they're all good, but they require different recipes based on which type of machine you're using. And ideally, you want to have it done with a 3 Tesla magnet. But again, if you don't have symptoms of classical TN, this is probably moot. This is, even if you see a blood vessel, the operation has much less chance of working for you, unfortunately. Next slide, please. And these are just some examples. So this is someone that doesn't have trigeminal neuralgia. There's just, you can see from the, and pardon me, I have to kind of look in here, but from the white arrowhead is pointing towards an artery, and the black arrow is pointing towards the nerve. And so that's an example where it's just touching. Next slide. A little more contact here where the arrowhead's pointing to the blood vessel, causing a focal compression. Next slide. And finally, you can see here with the arrowhead denoting the artery and the arrow denoting the nerve, you can see that nerve is actually bowed. It's kind of bowed like this, and that's what is meant by deformation of the nerve by an artery. Next slide. And when Dr. Zakraszewska talked about these different medications, and I should say, that our European colleagues are in, and part of why I want to say this is because there are a lot of individuals from the US on this call today. Our European colleagues, at least in my opinion, are much further ahead than in the US. So while there are some multidisciplinary clinics we heard a very good one yesterday. It's one of the reasons that the Facial Pain Association has developed the Neuralgia initiative is probably the number one initiative for 2024-25, is to try to get our neurologists on board. We're not trying to do surgeries on people who can't possibly benefit, but we're trying to help people who are stuck in neurology clinics not being recommended an operation that can really change their life. So this is, I should have prefaced this, but if looking at a cadaver specimen bothers you, please look away. But the red is around the trigeminal ganglion and nerve, and you can see there on the right, that's just an electrical test. Okay, so basically we tease apart those fibers, and we are able to, get an action potential. If you remember back to high school biology. Next slide, please. And I want to show you kind of fundamentally, this looks a little bit complicated, but not so complicated if you think about it. The y-axis there is showing how much you can, let's say, block that electricity, that plane, versus the x-axis, how much medication you have to give. And there's two different curves on each of those. And so one represents the trigeminal nerve, and one represents what's referred to as a sciatic nerve, or let's just say a nerve in the lower part of the body. Okay. And what we're trying to show here is that there's a profound difference in how the trigeminal nerve responds to carbamazepine. And why is that important? That's important because Dr. Zakrzewska and lots of other people have shown that if you respond to carbamazepine or oxcarbamazepine, just even whether or not maybe it becomes toxic to you, or you just don't like the way you feel on it, which is a major issue, it is predictive often of who will respond to microvascular decompression. Next slide, please. And so this is kind of our care pathway. And I wanted to bring this up because for those of you who are in the US at least, you might be saying, well, gosh, I wish I got to see Dr. Z, because, my neurologist is telling me, you're not ready for surgery. There's no reason to see a neurosurgeon. And so what I would suggest to you is that many of my colleagues on the MAB, I believe, would agree with me. Many of the neurosurgeons would say, we look to see, do you have symptoms of classical trigeminal neuralgia? And then did you respond to carbamazepine or oxcarbamazepine at least early in the course of the disease? Okay. And why that's important, we don't know, although we're really studying that in the laboratory. And then how much neurovascular compression? Is it just slight contact? Is it more deformity? And as Dr. Z pointed out, that seems to be really important. And then if you have classical symptoms, response to the drug initially, and some element of neurovascular compression, we're recommending microvascular decompression because, it's just so far superior to the ablative procedures. And that's kind of different information than you might have heard at this conference 10 or 15 years ago, when there was really a push to, let's say, gamma radiation or some of those procedures, which have a role, but they really should be reserved for different types of patients. So I'm just trying to be clear here for classical TN. Next slide, please. And so this is just one scoring system that we developed. It is not the final word. I want to be clear about that. There's a couple of other scoring systems, and our hope is that other neurosurgeons, neurologists, people like Dr. Z will critically analyze this and add to it, critique it. But it at least gives you some idea of what the differences are depending on your characteristics. Next slide, please. So we look just at those three characteristics. Do you have classical or non-classical TN? Do you respond to carbamazepine, oxcarbamazepine, yes or no? And what kind of neurovascular compression? And then we give you assigned points, 1 through 5. So 5 being basically the best candidate. Next slide. And these were our results 3.5 years after surgery. And this kind of at least partially explains what Dr. Z was saying when she said, listen, we 54% of our patients had surgery and 55% are pain-free. So Does that mean that the neurosurgeon in London is no good and he or she should be getting a 70? No, it does not. It means that, and whether they look at this way or another way, it means that they have a mixture of these patients in their system, 1 through 5s or however you want to categorize. So, and then when you put an average together, it's not going to be 90%. So, there are people that have a really it's a high predictability that they will do extremely well with the operation, and some not so. And so this is just information to try to help the patients understand who's a good candidate and who's not. Next slide, please. And that's it. I just wanted to kind of say that, and now I can open this up to questions for Dr. Zawska-Szewska and me if necessary. Thank you.
Thank you both so much.
And maybe Dr. Z, should I ask, is there anything that you disagree with in that?
No, I think that's perfect, and I think that's the important thing, that we are unified, or if we're not, that we discuss why we have differences. And again, our outcomes, the reason not everybody's pain-free is because among the surgical procedures include the ablative procedures. So it wasn't just the microvascular decompression. If you separate those out, then the outcomes are better. So
yeah, exactly.
All surgical procedures.
Well, that's a really important distinction. But also, if you look, and we don't need to pull back up my slide, but if you look at our grade, our score of 3, we're 44% are pain-free 3.5 years. If you look at 2s, 16%. So we're almost never doing 1s and 2s anymore now that we know that. But so again, that is not, and I think everyone knows that hopefully, but that is not meant to say, come to the US because no, that's not the case. I know the neurosurgeons in London, they have some outstanding neurosurgeons. So that's just kind of the results of a well-performed procedure on a heterogeneous group of patients with facial pain.
Thank you both so much. Incredible presentations. I would like to go ahead and jump into the questions from the audience here. We have several. So if someone starts off with having classic TN symptoms, and then it progresses over years to kind of develop into more atypical facial pain, are they still considered as having classical TN? What does that treatment pathway look like?
I think that's a difficult question because we haven't got a lot of long-term cohort, as we call it, data. And we still don't know how much it does change over time and what affects those changes. But I think if there is a neurovascular compression that is, and again, I quite agree with Dr. Zakula that it's got to be looked at, and I only trust my neurosurgeons to look at the scans. I don't trust the neuroradiologists again because they operate and they look at scans. So again, if even later on there is that element of neurovascular compression, then I think it's still worth getting on with having surgery. But they may be left with some element of what I call concomitant pain. And I think some of this is due to the fact that if you haven't used your mouth in an even way, and that's why we have physios, if you're not biting on one side and only using this side, well, it's not surprising that the muscles get slightly out of sync and therefore start to protest and give you some symptoms. So I think sometimes the why it becomes a sort of less classical appearance is because you get what we call musculoskeletal. It's a mechanical problem due to not using your mouth in an even way. And that's why we have physios to help our patients ensure that they are trying to use both sides of their jaw evenly.
Very good. Thank you. And yes, that's an important part because if you're using your mouth differently to adjust because of the pain, could that be creating other symptoms and issues that could be resolved? Here's a question about how does a patient decide on the next step after if they have a failed MVD or recurrent pain following an MVD, if meds are not adequately controlling the pain?
Should I have a bash first and then Ray can come in on that? I always stand back and review, and that's why having the baseline description of what the pain was like is crucial. And sometimes patients get a bit impatient with me because I spend so much time trying to find out what the baseline is. Because it's at this moment that I go back to my notes and I say, how does it differ from what it was pre-MVD? To try and establish, is there a true recurrence? And it could be for various reasons, which I'm sure Dr. Sakula will talk about. Or is this now something else? Has it developed into something else and therefore won't benefit by having surgery? Or is it just a temporary blip and it will settle? Over to you, Dr. Sakula.
Well, you won't find much that I disagree with Dr. Z about. I entirely agree with that. I mean, I always, when I meet a patient, I want to know, can you remember when this all started? And they'll say, well, they told me, no, I don't want to hear what they told you. Can you tell me, if you're not on trial, but if you remember, what did it feel like? How often did you have the pain? How long did the attacks last? So, but to answer this individual's question, I guess, like Dr. Z, I would do that. I would try to say, well, was it classical initially? And then we might re-image them and see, well, was something missed in there? Now, you've probably read and heard about this sort of burgeoning controversy of, well, does Teflon or felt? Teflon's a brand name, by the way, for Chemours, which was a subsidiary of DuPont, but it's a form of felt. And the question is, does that cause a problem? Well, people have had that in their head for trigeminal neuralgia for 40, 50 years. And while I've largely gotten away from using it a lot myself, I think the best we're going to see with not using felt is a couple of % difference. I don't think it's going to be more than that. So I'd be loath. I would be a little apprehensive if you're going to someone who's saying, well, this is because you have felt in your head or Teflon and we have to remove it. I mean, because the act of removing that felt in and of itself is injurious. And that's kind of like doing an ablative procedure. Please jump in if you disagree, Dr. Z. But so yeah. I would say that those are some thoughts, is to see someone, who, and there's plenty of people around the U.S. or if you're calling, you're in from the Europe or wherever, there's good people. And if you need help finding good people, call our organization. We can help you find someone. But, find someone that's experienced. If you're in the UK, make the trip to see Dr. Z because it's worth it to get a good opinion, I think.
Thank you, Dr. Sakula, for touching on the Teflon question. We did see a couple of those here in the chat and Q&A, so I appreciate you bringing that into the conversation.
Yeah, I mean, I should say there was just a pretty nice study where a neurosurgeon did 130 patients with Teflon and 130 without, and there's no difference. Okay, so, and every time we've brought up the idea of doing a prospective study, and I'm happy to do it. If anyone wants to do it with me, let's do it, because there is what's called clinical equipoise. We don't really know which one is better. So any IRB will approve this, where if a patient is willing to be randomized, we can do them with or without Teflon and see if there's any difference. But my guess, of course, I don't know everything, but my guess is at best you might see a few % difference long term. I think the bigger reason patients fail is for some of the reasons we said, which is not a personal reason patients fail, but because they don't have certain characteristics. They don't have all kinds of reasons. And there's all these really important areas that Dr. Z and others have been looking at, like this musculoskeletal issues with the jaw from not using it. I mean, these have been totally these are totally under appreciated areas, which I think I'm glad her group and others are really drawing attention to.
Thank you. Thank you both. Here's a question from Marie. How often should someone who's taking carbamazepine have blood monitoring? And then I'm going to add a kind of follow-up question to that. Is there any other monitoring that you recommend for patients who are taking anti-seizure medications to control their facial pain?
No, I think the important thing is when you first start the medication, that should be done definitely within 3 months. And then it depends very much on how high a dose you're using. So the higher the dose, the more frequent should be the blood tests. And I always recommend at least an annual one for everybody. But it is about the dosage you're taking. And it's the sodium levels we're looking at, what are called the urea and electrolytes, liver function tests. And then in longer term use, we need to look at folic acid, because that can be affected by long-term use of these drugs. So it's often, once a patient is stabilized, you don't need to use it as often. And again, depends on how sensitive different patients are. If you start to develop more side effects than usual, might be worth doing another blood test.
I just have one question for Dr. Z, which is not, well, let's say we are talking about just classical TN. How often, when you're seeing someone in your clinic and you've now gotten them in a good state with medications, how often do you dial down the medications for them, or do you just stay put, or what do you do?
No, what I suggest is going at least for 1 month with no pain at all, so that you can start to eat, touch your face, do all those activities. And if that's happened, then I recommend very slow reductions of 1 dose per month. So it's a very slow reduction and going back up if there's any return of pain. But
so what's a slow reduction for carbamazepine, for example?
200 milligrams once a month reduction.
Thank you.
Or 300 if it's the oxcarbazepine.
Thank you.
As a follow-up question to that, what do you see as a therapeutic level? Let's say an average patient who visits your clinic who is taking carbamazepine to control their facial pain. You mentioned therapeutic levels. What does that look like in kind of an average adult?
So in average, and again, it's very average because blood tests don't tell you the exact story. So as in some other anticonvulsant drugs, you can measure the blood levels. This is not helpful with carbamazepine. On average, 200 milligrams of carbamazepine 4 times a day is considered a reasonable dose, especially for women. In men, you can go up to another 200 before you get significant side effects. So that's the sort of, in a way, an average, but then you can go up or down on that. And the important thing is to spread the drug out, because carbamazepine needs to be taken 4 times a day, unlike something like lamotrigine, which can be taken twice a day. It again depends on the pharmacology of the drug. So I advise, and the other important advice I give is on the inserts with your drugs, most often, because it's for seizure patients, it says take after meals. Well, what's the point of a patient with trigeminal neuralgia taking it after they've suffered trying to eat their meal? So I say go against that advice, take your drug before a meal and have your meal possibly half an hour afterwards. I have an idea about how to tackle this in the future using some IT equipment, but I'm not quite there yet. But once I've developed that, I'll let you all know. But it is about finding your best dose. When are you at the optimum dose to then do the activities that trigger the pain?
Wow. Thank you for that answer and for the excitement and expectation of further research and treatment there. Thank you. Here's a great question from Rachel Scherer. Can the electronic pain diary be made available through the FPA? It would be so helpful.
Well, I hope so. The drug trial that is running in the US, and I know Dr. Sakula is part of it, I'm part of it in the UK, the basmiglucarant with Noema Pharmaceuticals, they have developed the electronic pain diary. They have said to me that they would make it available to us. So I'm hoping that once they've completed the trial and completed their various, we need to publish about its use, because we have evaluated its use in 20 patients and what they think about it. and the response has been fantastic. People have really found the electronic diary very helpful, and those patients who are in the drug trial with basmeglucurant are finding it of extreme benefit and very useful indeed. So I'm hoping that it will become available.
Well, Brandy, the FPA has been really helpful to Noema in recruiting patients. So in the future, maybe we can lean on, that's a great question. Maybe we can lean on them a little bit to make this available as soon as possible.
I think that's a great idea. And anyone who would like to learn more can visit the research page on the FPA's website. So facepain.org/research.
And we will be publishing, we've got a paper in progress about this electronic pain diary. So we'll let you know when we finally got it to print. So I think it is a useful resource, particularly as we often don't remember what our pain is like more than a week or when it's at its worst. Whereas with this electronic diary, you can look through a longer period of time and really see how it's developed over time.
Yes, I agree. I agree with that. It's very difficult to look back when you have maybe a 3-month appointment with your neurologist trying to think, well, how have I felt over the last 90 days, as opposed to tracking that where you can share that with your physician. I have a couple of questions that are similar. Do you do MVDs for patients with atypical trigeminal neuralgia? And then a second one is, can an MVD make kind of that TN2 type pain worse?
Well, I can start addressing that if Dr. Z wants to jump in. I mean, first off, I mentioned it yesterday. I think it was a good attempt, but I don't agree with the term type 2 TN, and it's largely gone away. And the reason I don't agree with it, the individual that developed it's a very good individual, but it's a bucket that holds a number of different types of TN inside of it. So I think it's very problematic, but I do understand what I think the questionnaire, the individual asking the question is saying is, if you have longer types of pain, do you do that? Well, I generally do microvascular decompression for individuals with classical TN only. And if their pain has transitioned over a period of years to having some more constant pain, then yes, I still consider that classical and I will perform microvascular decompression. I just haven't had very good results for individuals who don't have classical symptoms. There are colleagues, this is not just a US symposium, so I do have colleagues in the United States who would disagree with me, and that's, I think, important to know that there are individuals who will perform the operation for individuals with non-classical TN. But I don't, because I haven't had great success with it for the patient. Joanne, do you want to add anything there?
Yeah, and I think this is again where the history taking is so crucial. It's teasing out and spending time, and that's what physicians have a bit more of, is time to tease out exactly how much of it is classical and what is the other component of that pain and how it influences it. And so again, if as we call it now, the concomitant pain, if it's of low level aching type pain, then and everything else is classical, then again, I think it is worth potentially looking at a surgical option if there is MRI evidence as well to support that. But again, warning the patient that achy background pain may not disappear, so the results may not be as good as in the classic TN. But it is about getting that diagnostics right. And I know that Kim Birchall in Portland, Oregon, is working with a physio looking particularly at this musculoskeletal pain and his concerns, as you voiced, Dr. Sakula, is that the neurosurgeons don't always operate on the right patient. So it is care in the diagnosis.
And it's probably a good segue to say that that's part of, I think, Dr. Z may never get credit. I doubt she cares much, but she's been interested in developing a patient TN registry for a long time. And that's really it's happened, but now it's really happening. She's had a major input with the FPA. And I think that's part of, correct me if I'm wrong, that's what we consider to be an optimal patient or classic TN right now may look very different in 10 years once we have much more granular information from patients. Am I stating that right?
Absolutely. I mean, that's what we need, is what we call cohort data. We need a patient at baseline, and then say every 6 months or every year to be filling out a questionnaire that we give. And it's wonderful that the FPA is working very closely on developing this. And with AI now helping us, and big people who manage big data, because this is big data, this isn't stuff I'll be able to do. We need big data analysts who will look at this, and we might be able to come back with an answer to you. What percentage belongs where? What is the outcomes, using the outcome measures that I discussed earlier as well. So I think it's fantastic that the FPA are looking at regenerating the registry. We had one at the very start when it was first set up, the FPA, many years ago, but the problem was that we had such a heterogeneous, such a mixture of patients that we couldn't say definitely what the outcomes are. Whereas I think the plans for the registry now are that we'd be much more dictatorial about knowing how many patients have exactly this, how many have this character, where it is, much more granular data.
Yeah, because I would just say, Brandy, that when we talk about this classical thing, I can't present it today because it's just going out for submission for publication. But we're finding in that set there that when we look at our so-called classical versus idiopathic, which is a difference, that our idiopathics are doing much better than we expected. I mean, and some of the people with less compression are doing much better. So the way we're doing things right now is not surgically, but in terms of selecting patients. And I know Dr. Z would agree with this because she's been pushing me for more than 10 years. I mean, we remember we used to talk to Werner and 10, 15 years ago, and we didn't have the 225,000 it took to get it off the start. That was your idea. But, what we're doing in terms of selecting patients right now is a bit primitive.
Thank you both. And, something I've heard you share before, Dr. Skula, is having classical TN doesn't define you as a person. And if you have atypical facial pain or other experiences of neuropathic facial pain, understanding that just helps you get to the right treatment. Would you mind sharing a little bit about that? And that'll kind of be our last comment here.
Yeah, well, I won't, and again, I don't mean to, but I don't even I won't use the term atypical because I just think it's so charged. It makes people feel weird. I don't want to say, but I imagine it makes people feel weird, like there's something wrong with them. And in fact, there's many more patients with so-called non-classical forms of TN than there are of the so-called classical. So if, that just happened because clinicians had a better way with the typical patients or classical. They could do more for them. So I think that's how those terms got flip-flopped. But actually so-called classical TN or typical TN is really unlike any other neuropathic pain condition in the body that I'm aware of, with the exception of maybe paroxysmal extreme pain disorder. I mean, so really the kind of pain that most facial pain sufferers feel, that's the longer, dull, that's very much like other nerve pains all over the body. So there's nothing weird about you or wrong. And if there's anything wrong, it's us. We haven't learned enough yet. But we're trying, I think.
And I think I'd just like to hop in just to say another differential is, which is possibly more the Europeans are using, is SUNA, or short unilateral neuralgia form pain with autonomic features. And that is being touted as a variant, or is it the same as classic TN? And this is where patients will report that they have a runny eye, red eye, runny nose, swelling or a redness of the cheek, where there are these slightly different features that are visible. And that possibly is a variant, and again, a registry would collect that sort of data. So that's the sort of new diagnostics out there, the SUNAs, as we know them, and comparing those to what I sometimes say, trigeminal neuralgia with mild autonomic features. So that's another thing. So there are a lot of different mixes out there.
It's a great point, and it's also highlights a difference where our European colleagues, the neurologists and neurosurgeons, are working more closely together, and they are referring some of those patients for surgery, whereas in the U.S., very tough to get a patient with an autonomic cephalgia referred for a surgery, next to impossible. We've presented to our neurology colleagues. They like us, but that's part of what I think this neurology initiative in the U.S. in particular could be really helpful, that they can learn from some of our European colleagues.
Thank you. Well, hopefully the patient registry will help us understand if SUNCT and SUNA are kind of part of that spectrum of neuralgias affecting the trigeminal nerve. So thank you, Dr. Sekula and Dr. Zakshevska, for today's presentation, A Treatment Pathway for Classical TN.